My name's Katie Silk, I'm the Head of Therapies. Also joining me on the call this morning is Tony Wright. Tony, did you want to introduce yourself?
Thanks, Katie. Hello, everyone. I'm Tony Wright. I'm the Interim Associate Director of Nursing and Therapies for Clinical Support Services.
Brilliant, thanks Tony. So today we are going to be talking about our new campaign regarding deconditioning, in where we're going to make movement count. So this morning we've got a couple of videos to share with you. The first one being Mrs. Andrews' story. We're going to have a bit of a discussion afterwards. Hopefully that will stimulate a few questions and a few thoughts from you. Then we've got some facts about deconditioning, more about what it is, how it affects patients, and what we hope to do in the future to make it better for our patients while they're in hospital. So if we can go to the next slide, please, Nia. And the next slide is the video. So if we can watch the video. Thank you.
Oh, it's not playing.
My name is June Andrews. I'm 84. This is the story of my trip to hospital. It started one Friday evening when I had a fall in the bathroom. My husband called the out-of-hours doctor, who told us to call 999. Arthur couldn't help me get back up on my feet. I had a nasty bruise over my right hip. I wasn't keen on coming into hospital, but they persuaded me.
I was on call when Mrs. Andrews was brought in, and I arranged a hip X-ray. There was no fracture, but some blood and urine tests showed that she was a little dehydrated and had a possible water infection.
Mrs. Andrews was moved on to the acute medical unit. She was getting close to breaching the 4-hour target. It was also getting late, and the AMU was a safer place to assess her and get her back on her feet. We put up a drip and gave her some antibiotic tablets for the urine infection. On Saturday morning, she was seen by the on-call medical consultant. Before we could look at her mobility, the patient flow team insisted we move her to the first available medical bed. She was not reviewed again medically till Monday. There is no routine physiotherapy or occupational therapy over weekends, so we couldn't refer her to the home rehabilitation team before then. By Monday, June had been on either a trolley or in a bed with the cot sides up for 3 nights because she was deemed to be at high risk of falls, and the nurses had inserted a urinary catheter. She was seen that Monday morning by the physiotherapist, who got her out of bed with the aid of a Zimmer frame. My home ward is in the elderly care unit. We do our best to provide a regular liaison service to other wards, although we wish the doctors there had more knowledge about managing older patients. The ward doctors and occupational therapists made a plan to get some more information about June's usual abilities and past medical history.
I'm June's husband. On Monday, I was able to get back into the hospital to see her on the ward. I told the ward doctors and nurses that June had been getting more unsteady recently, had suffered another fall, and that her memory isn't what it used to be.
The review team discovered that her blood pressure was dropping very low when she stood up, postural hypertension. It often leads to falls and faints in older people. We stopped a couple of her cardiac medications to try and solve this problem. By Wednesday, she was able to stand with assistance. The physios came to see her, and a plan was made to refer her for ongoing rehabilitation in the local community hospital before going home. But not for the first time. There were no community beds, and by the 10th day of June's admission, the cardiology ward desperately needed beds for acute cardiac patients, and she was moved to a winter escalation ward. After all those moves, Mrs. Andrews had become confused and agitated. She had another fall, sprained her wrist, and now she required 2 nurses to transfer her from bed. June spent increasing time in bed with the cot sides up. By day 12 of her admission, the community hospital phoned back saying that she had no rehab potential and should have a care package instead. She was referred to social services with a target discharge date for Friday, but the package couldn't be put in place till the following Tuesday. She went home with a 3 times a day care package, but with no clear diagnosis for her progressive memory impairment and falls. 7 weeks after her discharge from hospital, June had fallen twice more. Her memory was worsening and Arthur was becoming stressed, concerned and exhausted. June ended up being admitted for respite to a local care home. Mrs. Andrews never got back to her own home after her respite. We should have more care and support for older people like her outside hospital, and those services need to respond much earlier to people's needs. But the way we treated her in hospital and our difficulty getting her back on her feet and home again didn't help. With so many frail older people coming into hospital, we have to get this stuff right for everyone.
So that's Mrs. Andrews' stories, and I'm sure that's quite a familiar story to some of us on the call today. I just wondered if we could have a little bit of a discussion about what your first thoughts are on that story. Does it sound familiar to you? How does it make you feel? And what if that Mrs. Andrews was your grandmum, sister, aunt? How would that make you feel? And I guess really, what are we going to do about it? What can we as individuals, but also as part of a team, do to support our patients while they're in hospital? If wants to put hands up or want to drop things into the chat, more than happy with either way. Tony?
Shall I start, Katie?
Brilliant.
I think I've now watched this video about 4 or 5 times, and each time it just pulls that little bit more about what we're actually doing to patients when they come in, and that we automatically put somebody into a bed, we put cot sides up, we're waiting for that assessment to be carried out, and we're doing it with the best intentions, but it's having that ability to step back and think, is this right for the patient? Should we be having more open conversations with the relatives to find out what is that person's baseline mobility like? Why do we automatically go into that mindset of thinking we need physio to assess somebody's mobility, we need OT to assess somebody's ability? Should we be having more work done with our ward staff to be able to allow them to be able to take on those initial assessments? I think that's my initial thoughts on it, Katie.
Yeah, brilliant. Thank you, Tony. Yeah, I think we hear that quite frequently. You know, perhaps a patient that might come in on a Friday afternoon, has the cot sides up, stays in bed until the Monday morning when, you know, the therapists do come into hospital. There's coming back to work. I guess, yeah, you're right. There's no reason why, having confirmed with relatives, with the patient themselves about how they normally mobilise, that we couldn't try that a bit sooner. I'm just looking at some of the questions we've got there in the chat. So Lauren has said, complicated process for our patients, and what we can do is just streamline it. Andy there, perhaps an all too familiar scenario. And Lauren, I'm also surprised at how quickly someone can decondition when they are admitted to hospital. Yes, for an elderly patient, it is very, very quickly, and we have got some facts on that a little bit later in the presentation to share. Giuseppe?
Thank you. I think I've only seen this video relatively recently and probably watched it about 4 times now, so it still gives me goosebumps. You really do think of how it could happen and how it could, if that was my mum, if it was my grandparents. It makes me think about how important it is to be involving family members and carers in kind of care planning and having them present on the wards as well to support. Because actually, when you from my experience, when you're talking to family members, actually they think about people go to hospital because they're unwell, and obviously they are here to do something, but it doesn't mean that people have got to be sitting in bed, that they can't get up, they can't mobilize, that they can't wear their own clothes or pajamas, etc.
Yeah, brilliant. And I think, you know, previously the trust has done quite a lot on the hashtag end PJ paralysis, and I think that is very very much a part of deconditioning, that it's also about how we teach our patients and our relatives to understand that coming into hospital, yes, there's a reason for it, but actually we still need to keep mobile, and just because you are in pajamas doesn't mean that you have to be in bed. And that's what, you know, the encouragement of getting up, get moving and get dressed is so important. Okay, thank you to those that contributed there. Nia, can we move on to the next slide, please? So this slide here just explains a little bit about deconditioning. So as a definition, deconditioning syndrome is the condition of physical, psychological, functional decline that occurs as a result of a series of complex physiological changes induced by prolonged bed rest or inactivity. It's commonly experienced by the older person in hospital, although it can affect people of any age. But the effect on the older person is more rapid, more severe, and often irreversible. So that diagram there just shows some elements of what happens during deconditioning. So people do become more confused and more disorientated. Pneumonia could progress due to prolonged bed rest, further immobility due to inactivity, increased risk of swallowing problems leading to pneumonia, clots in the legs and lungs, which we're all quite familiar with DVTs and PEs. Appetite and digestion can be affected, so they're not able to take in what they need to help their recovery, therefore more likely to stay in hospital longer. Skin breakdown, pressure ulcers, constipation and incontinence. So constipation because they're just not moving, incontinence because they can't get to the toilet. Increased risk of falls due to muscle weakness and muscle and joint stiffness, leading to reduced ability to walk. So all of them really, as you go round that circle, one can lead to the other, and they're all very much interlinked. Okay, next slide please, Nia. So in terms of for us as professionals, or for any staff that are just within the hospital thinking about our relatives potentially being patients, we need to try and prevent deconditioning. And there's three broad topics for doing that. So we need to assess. So a comprehensive assessment should be completed to determine usual capabilities. And that's very much what Tony raised there earlier about speaking to the relatives, getting to know our patients, making sure that we understand what walking aids they may need to be able to get around on the ward. We should complete a risk assessment. So that risk assessment should include whether they actually need the bed rails to be up. We shouldn't just put them up automatically. Do we need them up? And then making sure that they have their normal glasses, their hearing aids, their clocks and calendars, so that they can make sure that they're orientated to where they are, that they know it's morning and morning is breakfast and time to get up and get moving. Okay, next slide, please, Nia. So supporting them. So is there appropriate mobility aid available? And ask the question, is it the right size and is it reachable? So often on wards, we try to keep them tidy and clear, but actually a walk-in aid that's on the other side of the room isn't particularly helpful in giving the patient confidence to get up and move. Walking patients to the toilet helps them to prepare for going home. So is that catheter really needed? Should they be able to get up and have a wander to the toilet, not only helping with their activity, but help prevent incontinence as well? And sitting in the chair can absolutely help. And so we should be asking everyone, do you need help to get out of bed? Okay, thanks, Nia. Next slide, please. And then encouraging patients. So encourage them to feed and take fluids independently. Obviously, to do that, they need to be sat up appropriately. So again, sitting out of bed when they can. To wash and dress independently and get into their own clothes. So we know when it's morning, we get up, we get dressed. At night time, we get undressed, we put our pajamas back on. So keeping some form of normal daytime routine for our patients, and to keep their arms and legs moving, even if they are in bed or on a chair. Okay, thanks, Nia. Next slide. So this is another video here just about some facts on deconditioning.
Fast facts about deconditioning. If you're over 80, 10 days of bed rest equals 10 years of muscle ageing. 60% of older patients have no medical reason for being on bed rest. 46% of people over the age of 85 die within 1 year of hospital admission. Hospital inactivity equals accelerated bone loss, malnutrition, delirium, sensory deprivation and incontinence.
By contrast, a 50% increase in walking while in hospital is associated with a 6% shorter length of stay. Implementing NPJ paralysis in a trauma and orthopaedic ward in Nottingham University hospitals led to a 37% reduction in falls, 86% reduction in pressure injuries, and 80% reduction in patient complaints, and a spot audit showed a reduction in length of stay of 1.5 days. Here is just some of the evidence. So, get out there and end PJ paralysis today.
Brilliant. Okay, next slide, please, Nia. So I'm now going to ask Caroline Ashton to come in and give her experience of a patient that she shared with me recently, that how deconditioning actually affected this patient and what their end story was. So this was a patient that was at PAH. Thanks, Caroline.
Hi, morning everybody. So this is a gentleman I supported between Christmas and New Year. I received a referral for this gentleman, and the reason for referral was typical referral for me, non-compliance or behavioural issues. So I went off to the ward to see this gentleman. He was in a side room. He was lying in bed. The cot sides were up. He was wearing hand control mittens. He was just literally staring up at the ceiling. His mouth was really dry. This gentleman came into hospital following a fall. He had a history of vascular dementia, which was quite newly diagnosed. He was living at home independently. There had been some concerns about his care needs at home. He'd had a package of care previously on a previous admission, but that had been stopped because he was managing quite well. He then came in, as I said, with a fall and some delirium. And in my patient group with dementia, having delirium on top of dementia is a huge problem and can increase the risk of mortality by 40%. This gentleman, when I looked through the notes to get a really comprehensive assessment of what his needs were, I saw the initial clerking from the therapy team that he was mobile prior to admission. He was actually walking daily into the town centre to go to the shops. He would often catch a lift from one of the ladies in the supermarket he knew to get back home, but he did that 10 to 15-minute walk every day. And now there he is lying in bed. I spoke to the ward staff. They said to me, as far as they knew, he was bedbound. So I say, this is a gentleman that we've made bedbound in the period of time that he was in hospital. It was over a bank holiday. I spoke to a physio that happened to be walking past that was on call, and I said, you know, this is the clerk in therapy notes say he was mobile. I'm okay to get him out of bed, and I took that judgment myself and got him up. He had good sitting balance. He sat in the chair for a good 2.5 hours with me. We had a shave, did some orientation work, watched TV, had some music, and he ate and drank and cleaned his mouth, and he was really, really content to be in the chair. Put him back to bed safely before I left, of course, and I phoned his daughter, and she just said she thought he had to stay in bed. She didn't want to challenge it, and she was a nurse herself as well. She thought it's because he was too unwell he needed to stay in bed. In fact, he tested positive for COVID and now was negative, so he could have got out of bed, and he certainly could have come out of the side room. After about 5 days, unfortunately, he aspirated, he deteriorated, and I got called back to the ward because of distressed behaviour. In fact, he was approaching the end of his life. He was agitated at the end of his life, and his symptoms weren't very well controlled. And we did refer him to a hospice, and he did get discharged there for end of life care. When Katie said at the beginning, what could we do as a team? I feel, for me, bringing that person-centeredness back into handover, knowing our patient's story is so important. I know it's important to know how many high-risk fallers we have, how many people are walking around, how many people need help with eating and drinking. I don't think we know often enough our patient's story. You know, who is that person in that bed? It isn't just somebody with dementia, it's somebody that's had a life, somebody that is mobile, somebody that likes to do things for themselves, and that's so important. So what can we do collectively as a team? Making sure, as Giuseppe said, talking to our families. I've been a family that supported someone with dementia throughout the pandemic, and I wasn't even allowed to visit on one of the wards. And I'm a dementia nurse, and my father-in-law had dementia, and I was stopped visiting. So I think it's so important. Engaging with our families is just so important to do that, and they can help support us too. But completing the This Is Me, not having any restrictions on visiting, and certainly reviewing the hand control mittens, because that would have made a difference. Like one of the slides said, encourage people to eat and drink. There's been many times when patients have been wearing mittens when actually they could feed themselves. So that's my story, and that's one of many in terms of people with dementia. And we do talk about this a lot on induction and all the training that I do. But and it's quite an emotive topic for me, as you probably sense. But it's kind of what I wanted to say. But the daughter was extremely happy that he got off to the hospice for end of life care. So that was a good outcome. Thank you.
Brilliant. Thanks, Caroline. I've tried to summarise a little bit on that slide there, the main points that I think have come out of that story. So the importantness of finding out what our patients can and can't do, and encouraging them to move as soon as possible, even if they are in a side room and isolated and are COVID positive. It's still, if they're well enough to, we should encourage them to get up. And just picking up on the point there in Caroline's story that, you know, we assume that they were bedbound, which is a very, you know, quite a significant statement to make, given that this gentleman was actually walking quite a distance into town every day. And yeah, my last point, get patients up, dressed and moving is everybody's. It's a team responsibility, and to make that movement count. Okay, Nia, can we move on to the next slide? So here I'm just sharing some really simple exercises that everyone could do. So any patient on any ward, as long as they haven't got restrictions on their movements, perhaps for fractures and things like that, could be doing. So the first big picture there is what we call an ankle pump. So it's just pumping your feet up and down. So keeping your ankles moving, but also helping with circulation while you're in bed. The other side of the screen there, the top one, is what we call a static glute. So it's squeezing your big buttock muscles effectively, so clenching and releasing. They are the big muscles that we use in order to stand and to walk. So it's, you know, they're the ones that we need to keep strong. The one at the bottom there, the knee pointing downwards, so that's what we call a static quad. So that's tightening up your big thigh muscle. And the wording we tend to use is that you're pushing your knee down into the mattress or into the bed that's underneath you. Okay, next slide, please, Nia. And then when they are sitting out of bed, two quite simple exercises, just marching on the spot, lifting those knees up as high as they can. And then the other one is straightening, just straightening your knees, holding your leg up in the air one at a time. As they progress and get better, the aim would be to hold it up for as long as possible, so you're sustaining the muscle contraction in that leg. Again, those are the muscles that we need for standing and walking. So if they're not able to do that themselves in terms of standing and walking, they can be doing exercises while they're sat in the chair or in bed. Brilliant. Next slide, please, Nia. Now, obviously, the Trust is launching this big campaign, so you may start to see posters, banners, and patient information going home to relatives about what this is all about. I guess the important thing that we need to be sharing with patients is that they're part of this. They can certainly ask for help to be able to get up and start moving, or ask for assistance to walk to the toilet, and then anyone on the wards could be able to facilitate that. And for relatives, making sure that they're able to bring in the appropriate shoes for them to wear, slippers or good fitting slippers or shoes that they can wear on the wards, as well as their own clothes, so that they can get into the routine of still getting up, getting washed, getting dressed while they're in hospital. There are a couple of links there to what we've got for staff on AlexNet, and then for patients and relatives on our main PAH website. Thanks, Nia. Next slide. So in summary, 3 quick tips. So make sure the patients have got their own adjuncts. So for walking aids, for hearing, for glasses and slippers. To remind patients and relatives regarding the expectations of getting up, getting dressed and getting moving. And all patients that can should sit out of bed, especially for meal times, to ensure that they are able to eat and drink and swallow properly. Helps with their digestion, helps with constipation and prevents incontinence. Okay. So next steps for us, tomorrow is Clinical Friday, and there will be staff going around the wards tomorrow, hoping to get some pledges from staff about what we can do to prevent deconditioning in our patients in our hospital. Wear your trainers to work day on the 20th of January. So everybody in the trust, so not just people clinically, but people in offices wearing their trainers to work, to promote conversation about deconditioning and how we can stop it. We're trying to get up and running some exercise groups, so perhaps around late morning, early afternoon, having somebody that can come to the ward to get those 5 exercises going for all of our patients with demonstrations. I did have an idea a while ago about ringing a bell 3 times a day, and that everyone stops what they're doing and helps the patients complete those 5 exercises. We'd love to be able to start some group lunches on the ward, and our aim is to start with that on Thai Green ward, so getting some tables out and those patients that can get up and walk or get up and sit in perhaps a wheelchair be brought to the table so they can sit together as in a social environment to encourage eating, drinking. And then lastly, this is everyone's responsibility. We need to keep our patients at the heart and make sure that they don't decondition when they come into hospital. Next slide. Any questions or anything anyone would just like to say, or any ideas about what we can do in the future? Janice?
Hey. I just wanted to say, the availability of the volunteers and deconditioning is not just about physical, there's also the cognition side. So we do in Opal unit quite a lot of activities that is chair-based or bed-based if they can't get out of the bed. So volunteers are always contactable and they're happy to always flex and provide some support on any clinical areas.
Yeah, thanks, Janice. We are working with our volunteers in terms of what they can and can't do with actual patient contact and facilitating exercise and helping with getting out of bed. But yeah, we're working on that one. That's a great idea. Thank you. Caroline?
Hi, I just wondered, on a Friday afternoon, generally I do bedside activities, sometimes armchair exercise or namaste or singing. But I've often wondered if there's any possibility we could recruit an activities coordinator who could then maybe roll out some of this work. I don't know if that's possible, where that will be funded from.
Great idea, Caroline. I can certainly take that back to our deconditioning group that are working on this campaign and see what we can do about that. Absolutely, great idea. Okay, I can't see. Oh, Tony.
Yeah, just a final thing, really, for everybody that's on the call today that potentially won't be involved in Clinical Friday tomorrow. Could you start to think about what your pledge is to help with tackle the issue of deconditioning? What pledge are you going to help to support our patients to get up and to get moving? And I think, Nia, I'm going to put you on the spot here. If anybody has got a pledge, if they can send them through to us, and then we can get them coordinated, that will be absolutely fantastic.
Yeah, brilliant. Thank you, Tony. All right, I think we've come to the end now, so I'm going to end now, if that's okay with everyone. But thank you all very much for joining, and let's spread the word as much as we can.
Thanks.